All right. Good morning, everyone. And thank you very much for joining us this morning for our final presentation in our month-long series of infectious disease, immunization, and staying healthy in body and mind. As we gather here today, it's vital we remember the peoples who've gathered here for millennia. This is the Treaty 7 land of the Indigenous peoples of Southern Alberta, the Blackfoot Nations of Siksika, Piikani, Kainai, and the Tsuut'ina First Nation, the Stoney Nakoda Nations of Chiniki, Bearspaw, and Wellesley, and the historic home of the Northwest Métis and Métis Nation of Alberta, Region 3. It's with the goal of reconciliation that we acknowledge the land on which we gather, and we thank the elders of these nations for their timeless contributions to this land. And we know that the last 9 months have been a particularly difficult time for our seniors, and many of you have had very genuine concerns about how to lower your risk and to maintain good health in the midst of the pandemic and upcoming flu season. Over this past month, with the support of an educational grant from Sanofi Pasteur and the several renowned medical professionals, we hope that we have answered some of your questions for you and have provided you with the information you need to ensure your good health. We're very excited this morning to have Dr. Patrick D. Mitchell, MD and Clinical Assistant Professor of Medicine at the University of Calgary. Dr. Mitchell trained as a specialist in respiratory and internal medicine in Ireland and joined the University of Calgary respiratory team in 2016. He has also been appointed Director of the Asthma and COPD program at the Rocky View Hospital. Whether due to COVID-19, pneumococcal, or pre-existing COPD, the prevalence of respiratory infection is a serious concern for older adults today. Dr. Mitchell, tell us why older adults in particular should be conscious of their respiratory health. You're muted, Dr. Mitchell.
Older adults have traditionally, I suppose, have a higher incidence of a past history. First of all, unfortunately, the older you are, the more lung function that you've actually lost. So by the time you're 25, so something that is behind all of us here, your lung function actually starts decreasing at approximately 30 milliliters per year. Now that's absolutely fine, and you could live to about 170 with that decline and still function fine because obviously you've got two lungs and it gives you a good bit of reserve. And by the time you hit your late 60s, obviously that's decreased a little bit more. It does leave you more susceptible if you do actually develop a respiratory tract infection to losing an area of lung which would be traditionally available to you for oxygen transfer in and out. The second issue is that traditionally our older population have had worse habits in terms of a smoking history than the younger population going through. So if you look at the prevalence of smoking amongst, for people who have a 10-pack-year history, which is smoking 20 cigarettes a day for the last 10 years, it's an awful lot higher in our seniors than it is in our teens or our 20s or 30s. So the smoking incidence now, although vaping is a serious concern in our youths, is down at about 17%. Where if you look back 30 years ago, approximately 35% of the population were smoking. So that's obviously had its longitudinal impact. The other thing is that unfortunately over time, the immune system becomes somewhat compromised in our older folk and leaves them more susceptible to developing the adverse effects of traditional, any kind of a lower respiratory tract infection. The other issue is that unfortunately, as we get older and as we age, we tend to accumulate other ill healths such as diabetes, heart disease, frailty, weakening of the muscles. And those in themselves actually can compound the adverse effects of developing a respiratory tract infection. So the synergy of that leads to an overall worsening lung health in general, which means you're more susceptible to developing a respiratory tract infection and less able to fight it off. Now, there is a flip side to that, and I just wanted to, before I actually went on, my presentation is a little bit atypical to what you're usually used to. I thought I'd try and make things a little bit interesting in terms of, because we are living in the middle of a pandemic, and briefly run through some of the pandemics that we've suffered in our history to let us know that, we're not alone. This isn't the first one that's happened, and it won't be the last. And just how it's affected us and actually how it's affected society going forward, and who knows what COVID and the adverse effects will be. Then I'd like to talk a little bit about lung health in general. There's not an awful lot to talk about lung health. It's common sense issues, an awful lot of it. but I will go into that, and then obviously finish off by having an in-depth conversation about COVID and where we are. So I can get cracking. I'll share my screen with you if you'd like.
That would be great.
Perfect. Okay.
Perfect.
Okay, so lung health and respiratory infections. And thank you all for coming along to this webinar today. And thanks for inviting me. It's a pleasure. So, history of infectious diseases, common respiratory infection, COVID, and conclusions and questions. So, what is a pandemic? So in the realm of infectious diseases, a pandemic is the worst case scenario. An epidemic is when an infection is within a country's borders, and a pandemic is defined by the WHO, so the World Health Organization, as when it becomes, when it essentially crosses borders. Communicable diseases have existed since really man went from a hunter-gatherer to shifting to agrarian or farm life about 10,000 years ago. This made diseases much more communicable and easily passed. So you had endemics, which were in particular regions, epidemics, which are defined as within countries, and pandemics, which are pan-country. And the first critters to really start affecting humankind was malaria, tuberculosis, leprosy, influenza, smallpox. Now, how do we know these things? A lot of the data is collected from anthropological archaeology. So looking malaria, you can actually, and also DNA analysis. So you can actually do quite quantitative DNA analysis of old bones, etc., and pick signatures of these diseases up. So the first major plague that we have on record is the plague of Athens. So it was around the Phoenician War after disease passed through Libya, Ethiopia, and Egypt. Now, the really interesting thing is we think this was actually typhoid and typhoid fever. And the symptoms that were actually recorded were fever, thirst, blood in the throat, tongue and skin lesions. And that's why we think it was typhoid. And the interesting thing is, how did it actually affect humankind? Well, we think that it greatly weakened the Athenians and was a significant factor in the defeat by Sparta. So the plague of Antonine. So again, we're not really sure exactly what this was, but we think it was when smallpox really started to appear and caused its first plague, beginning with the Huns. Then with the Cyprian plague, named after the first known victim, which was a Christian bishop of Carthage. Now, this plague is to have caused widespread manpower shortages and food production for the Roman army, severely weakening the empire in the crisis in the 3rd century, and actually precipitated its decline. The first major plague and first bubonic plague caused by Yersinia pestis was the plague of Justinian in 541 AD. It's thought to have actually eventually killed about 50 million people. It was also credited with creating such an apocalyptic atmosphere that it spurred the rapid spread of Christianity. Leprosy then in the 11th century, known as Hansen's disease now, it had actually propagated, and some people really pushed forward some of the dark ages in terms of belief that it usually moved in families from generation to generation because of their cohabitation. And people believed that it was the wrath of God on these families that was causing it. Then we've all heard of the Black Death, the bubonic plague. It ravaged the populations of Greenland. Vikings lost strength, and indeed, they actually halted the Viking exploration of North America. And the Great Plague of London, 1665, another devastating appearance of the bubonic plague. 1 in 5 people died. As the human death tolls mounted, mass graves appeared. The phrase, "it's raining cats and dogs," actually comes around from this time. Cats and dogs were also affected. And in the great rains of 1665, cats and dogs were seen being washed down streets, hence the phrase. And the first cholera epidemic was in 1817. So this killed millions of people. And then we all know, bringing us up now to the era of these viral infections, or the Great Spanish Flu of 1918. Now, this resulted in more deaths than World War I, 50 million people. It was called the Spanish flu as a result of wire services reporting a flu outbreak in Madrid in the spring of 1918 being led to called the Spanish flu. By October, hundreds of thousands of Americans had died, and body storage capacity hit crisis levels. But the flu disappeared in 1919, and this is what's really interesting, especially in the era of COVID, is why did it disappear? Well, most people had actually become infected or died. Interestingly, it led to an increase in life expectancy as individuals who had chronic diseases such as tuberculosis with weakened immune systems were taken out by the influenza virus, passed away, and led to an actual overall statistical increase. And then there was a massive baby boom in 1920. HIV, a more novel viral infection, first identified in 1981. It's unfortunately killed off close to 40,000 individuals. Treatments have been slow, but we've now very effective treatments to treat it. Now, bringing us up to the era of COVID infections. So we've got MERS, which is the Middle Eastern Respiratory Syndrome. This is a deadly coronavirus. Its mortality rate is about 30%, compared with 3% for COVID-19. It was spread from bats to camels, but the traditional route is actually from camels to humans. Really, I obviously call the Middle East because it broke out over the Middle East, especially in Saudi Arabia. There is still the odd outbreak of this now. Typical symptoms include fever, cough, diarrhea. The first attempt at a vaccine towards the coronavirus, or any coronavirus, was MERS. It was actually developed by the US Army, but then this virus essentially disappeared, so they put the actual vaccination plans on the shelf. SARS, first described in 2003, it killed 779 or 74 people. Started in China, possibly spread again by bats, then spread to cats and then humans. Characterized by the usual problems that you'd find with the coronavirus: dry cough, fever, headache, body ache, respiratory problems. Quarantine efforts were rigorously enforced and actually worked. But China was heavily criticized for trying to suppress the information about the virus. They didn't really let the WHO know that there was a problem when they knew there was a problem for about 4 or 5 months. And SARS was seen as a global health professional, as a wake-up call to improve outbreak responses. And lessons from pandemics were used to keep diseases like H1N1, Ebola, and Zika under control. So pulmonary infections. What type of infections are we susceptible to? Most of us pick up 1 or 2 viral infections per year. They're usually a rhinoviral infection. Rhino meaning nose, viral obviously viral, and that's usually where they start. They're very, very common. Why do we continually get a cold virus, a rhinoviral infection? Surely we should become immune to it. One of the big problems is because there's about 90 different subtypes, and you have to become immune to each subtype. The second problem is that essentially the vaccine, or even getting an infection and that long-lived immunity that you see with measles, is just not there with these viruses. So you get them periodically, yearly. Obviously, bacterial infection. The major ones that we worry about in terms of ourselves are strep pneumonia. That's why you guys get your pneumonia or pneumococcal vaccine once before 65 and once after. There's obviously 2 different types. The reason there's 2 different types is when you look at strep pneumonia, there are about 80 different types of it, or subtypes of it. And what the vaccines try to do is cover the commonest types. So the Peptidase 13 covers 13 of the common types, and the other 23 common types. And then fungal infections. We really don't see an awful lot of fungal infections in people who are immunocompetent. That means their immune systems are fully functioning. It's individuals who are immunocompromised, such as those who are undergoing chemotherapy, those who are sick with cancers, or those who have HIV or advanced HIV. And again, parasitical infections, very rare in developed countries. We do see them in less developed countries due to water sanitation. So good lung health and preventing infections. Well, obviously the first and foremost is smoking cessation. This is a must. A cold or other respiratory tract infections can become very serious. And there's several things you can't really do to protect yourself. So it's washing your hands with soap and water. Alcohol-based cleaners are good if you can't wash. However, washing with soap and water probably is nearly just as good. Avoiding crowds during the cold and flu seasons. Good oral hygiene. This is especially important in our older folk, especially those with dentures. Unfortunately, oral flora can actually aspirate into the lungs and develop nasty infections. Getting your vaccination against an influenza on a yearly basis, and pneumonia vaccines. And if you get sick, as I say, keep it to yourself. You got to protect the people around you. The other thing is social distancing, especially obviously in the era of COVID. This I know is really difficult. I have, grandparents at home who can't see their grandkids, their kids, their friends. It's especially difficult from a mental health perspective, which is why things like this are so important, but do keep in touch. So COVID-19, and what is it? So it's a coronavirus, which are a group of RNA viruses that cause disease in mammals, ourselves, and in birds. So RNA, so we have DNA, and an awful lot of viruses have RNA, and it's just a simple form of DNA. So there's nothing else you need to know about it. The reason it's called a coronavirus is because when they looked at it under the electron microscope, it looked like it had a corona like you see when you look at the sun, hence the name. So it does cause respiratory tract infections. They range from really asymptomatic infection to mild infection to unfortunately lethal. There are common varieties as we discussed, which we really do worry about: SARS, MERS, and now COVID. The first human coronaviruses were discovered in the 1960s, but they've obviously been around for a long, long time. So what happened here? At the end of 2019, a novel coronavirus was identified as causing a cluster of pneumonia case in Wuhan. Now, we do know that we really have data that suggests that it started to break out at the end of October, early November. It rapidly spread, resulting in an epidemic throughout China, followed by the global pandemic that we're living in. The closest sequencing that they do when they look at the signature, the kind of the molecular signature, the RNA, shows similarity between two bat coronaviruses, and it appears that bats are a primary source. Whether it's directly transmitted from bat or through another mechanism, through an intermediary host, is unknown, but we now know it is human-to-human contact. So direct person to person. So we do talk about the 2-meter rule. Data, unfortunately, is coming out that mightn't be as, and I'll get into that, as robust as we initially thought. This hand to mucus surface. So if you have a cut in your skin, you're not going to get COVID through that. But if you pick up something that has COVID on it and you rub your mouth or your eyes or your nose, you could become infected. There are scattered reports of COVID outbreaks. So it's SARS-CoV-2 is its formal name, in restaurants and on buses. And this has actually highlighted the potential for longer distance airborne transmission in enclosed, poorly ventilated spaces. So estimated are just about 1 in 10 to 2 in 10 of those carrying COVID may be causing about 80% of new infections. These are, some people refer to them as these super spreaders. As it's airborne, a rising concern is that there's no safe distance in poorly ventilated rooms. Now, this is a serious concern as we get into the winter months, especially in northern climes, in the northern hemisphere. So we now have such good architecture that the ventilation is essentially nil in an awful lot of the buildings that we live in, which means if someone walks into a very large room and they have COVID and it's airborne, they could be spreading it. So that is a concern. So it's been detected in non-respiratory specimens as well, including stool, blood, ocular secretion, semen, but the role of these sites is still unknown. The one I would point to, actually, interestingly, is stool. So why is this interesting? Well, we're actually using the sewage systems here, and they're using it in several other countries to try and track whether there's an increase in COVID cases, and indeed asymptomatic COVID cases, which could be up to 80% of people. And we're actually looking for that trace signal, the PCR of that RNA that I talked to you about, to see whether there's increasing levels to say, there could be a problem here. There's no evidence that SARS can be transmitted through contact with non-mucous membranes, as I said, such as a cut in your skin. So what's the period of greatest infectiousness? So infected individuals are more likely to be contagious in the earlier stages of their illness, when the viral levels are highest in the upper respiratory tract. In one modeling study, in which the mean serial interval between onset of symptoms among 77 transmission pairs in China was 5.8 days. This suggests infection started 2.5 days prior to any symptoms. So these people could have been walking around, seeing people, hugging people, etc., for 2.5 days before they knew there was a problem. So what are the treatments that we have? Well, supportive treatment is the mainstay. Most people don't require any hospital care. And what I mean by supportive is bed rest, hydration, acetaminophen. About 20 to 15% of people will require hospital care, and usually in the form of supplementary oxygen, which is the nasal prongs or a mask or a nebulized nasal prong that you've seen. About 7 to 5% of people who become infected that are symptomatic will proceed to needing something called NIV. This is non-invasive ventilation. This is where a mask is placed in your face and blows oxygen at you. And about 2% of these people, unfortunately, will proceed to frank intubation, where they need emergency ICU care, and a tube is put in as a breathing device, and they're put on an artificial breathing machine. The only two treatments that have actually been licensed to date and validated by trials, and I'll show you those, is dexamethasone and remdesivir. These are the two agents that Donald Trump had when he was admitted to hospital. Trial agents currently are plasma, which is where you get the plasma, which is the watery part of your blood, which contains antibodies, from people who've recovered from COVID, in the hope that they've developed antibodies, and those antibodies will be put into people who have active COVID infection to try and stop the virus from binding to cells. Interferon, which is a common treatment, it actually induces the immune system to attack viruses. Anti-HIV medication, something called Calatra, and then hydroxychloroquine. Now, hydroxychloroquine has been dropped because of its lack of effect, and indeed there might be a link to more harm than good. So remdesivir, it works, but only mildly. And what I just pointed out to you here, when you read the newspaper, they say, oh, we have a golden bullet to treat COVID. So, and they talked about this, and I read about it in the press myself, it was remdesivir. And the Kaplan-Meier estimates were, if you were on remdesivir and you were sick with it and in hospital, your mortality was 6.7% with remdesivir and nearly 12% with placebo by day 15. And at day 29, you obviously, a few more people unfortunately passed away. And if you were on the drug, 11.4 people died. And if you weren't on the drug, 15.2% of people died. And dexamethasone was a bit more robust. And what I mean by that is that you were in the intensive care unit on a breathing device and you received dexamethasone, which is a steroid. 30% of people passed away, as opposed to 41% of people who weren't on the steroid. So vaccination. Unprecedented efforts are underway to develop a COVID vaccine. Usually a vaccine takes several years to process through. We're trying to do it in a few months. We're also using a new technology. We're using, essentially, we're grabbing a little part of the genetic signature of the virus and putting it into people to try and provoke an immune response and a long-lasting immune response. So if you do actually get the full virus, your immune system recognizes it immediately and neutralizes it. There are several trials. The New England or the New York Times does a very good vaccine tracker. There are currently in phase 1, which is very early, 35 vaccines. And in phase 3, which is getting ready to actually potentially give to the public, there are 6 vaccines, but none have been approved yet. There's talk of some coming out in December, January, but they have to be mass produced, mass given, and also the uptake needs to be very good to achieve what's called herd immunity, which I'll talk to you about. And this is what I was talking about, these genetic vaccines to deliver one or more of the coronavirus's own genes into our cells to provoke an immune response. So what's herd immunity? Boris Johnson in the United Kingdom, in the initial phases of COVID, said, we'll do it through herd immunity. What he meant by that was enough healthy people who get the virus will become immune for it and therefore won't be able to spread it anymore and won't be able to get reinfected. And those folk who can't take vaccines for some reasons or are old or infirm won't be seeing as much as a vaccine. Herd immunity has never been effective in any type of infectious disease in the history of mankind. Vaccination causing herd immunity has been. Now, in saying that, one minor example of where it may have had a response was in the 1918 flu, where it obviously disappeared by 1919, 1920, because a lot of people became immunized. But that was at a cost of 50 million lives. That's too many. And think about the population back then. It was, maybe about 1 billion people. And there are also major problems with relying, as I mentioned, to community infection to create herd immunity. I mean, I don't know if you guys remember, I was just born after the era of measles parties in Ireland, where kids, if a kid had measles, all the kids from the neighborhood would be thrown in the same room as him. So the US estimates that 70% of the population, that's more than 200 million people, would have to recover from COVID to halt the epidemic, provided that that you became immune for at least 12 months, which we don't know if you do. However, in the process of doing that, millions would die and the global healthcare systems would completely collapse. So COVID and reinfection. There have been 4 cases described, as you can see on the table on your right as you're looking at the screen, of individuals who were documented to have developed COVID-19 infection and became reinfected. So worryingly, reinfection tells us that we cannot rely on immunity acquired by natural infection to confer herd immunity. Now, in saying that, there's only been 4 reported cases. There may be many others, I'm sure there are, but it's still not enough to get extremely worried, but it's still worrying. It's also worrying in terms of vaccine implementation and efficacy and the creation of a long-lasting immunity to COVID-19. So what's the bad news and why do we worry about our seniors? The reason is unfortunately that you're more likely to suffer adverse events from COVID-19. Unlike the Spanish flu pandemic of 1918, where the vast majority of mortality was between the ages of 20 and 40. So this is not the case with the COVID virus. So if you can see here, I just want to go through a few things. COVID deaths and ICU admissions. So you can see the older you are, the more likely you are to die if you develop COVID. You can also see that the ICU cases rise the older you are. Now they drop off very quickly after the age of 79. Now the reason for that is not unfortunately because these people didn't need ICU, but an awful lot of these people weren't fit for ICU or had elected not to go to the intensive care unit. This data is from British Columbia. So just a complicated table here, but again, if you're looking through percentage of deaths from COVID here, it just seems to be, and what the weird one is actually, is between the ages of 80 and 89, you're more likely to pass away than you are if you're over 90. The theory here is that individuals who are lasting into these very late years actually have an inherent bias towards survival. So long haulers, I didn't want to populate this slide heavily. We've set up a post-COVID clinic at Rocky View General Hospital. There's one up in Edmonton to look after what we would describe as long haulers. So the first kind of long hauler case that was really described was in 1892. The English social reformer of women's rights, Josephine Butler, and she wrote of suffering months after the Russian influenza pandemic of 1891. And this was written actually in the Gregode, tout le monde, influenza, watch for influenza. And the age respondents for prolonged COVID symptoms. So these are people who are experiencing COVID symptoms after 3 months. And as you can see, the age bracket that's predominantly affected are between the ages of 30 and 49, taking up 63% of all cases. Now, what is a long hauler? What's the definition? There is no strict definition at this stage, but essentially it's someone who has failed to get back to their pre-COVID infection baseline after 3 months. Now, it's more common in patients who obviously received intensive care, but this is not an unknown phenomenon. Patients who receive intensive care and who are intubated, etc., suffer from lots of things like a critical care myopathy, which means weakness of the muscles, and need a protracted rehabilitation phase. But what's happening in individuals who've developed COVID-19, unfortunately, I have two colleagues in work who developed COVID in April and May, and they're back at work. But both of these were guys in their early 40s, very fit, active individuals. And after they finish their shift or get home in the evening, they said, I just fall asleep, I can't do anything, can't play with the kids, can't do anything. So this chronic fatigue is a major feature of long haulers. The other issue is heart damage. So a lot of these people, when they undergo an echo of their heart, which is a gel test like you would do to see babies, but you do it of the heart, we can see that the heart muscle, even after 3 months, isn't pumping as well as it should, which is called a cardiac myositis. So that's obviously concerning in terms of the long-term effects of this virus. In terms of pulmonary function, we're seeing patients develop scarring of the lung, long-term scarring of the lung, bronchiectasis, which means an aberrant dilation of some of the airways, which can lead to further infections from bacteria. And we're leading to changes in their lung function, where there's a decline in their lung function, and breathlessness. In terms of strength, we're seeing people who are feeling just very weak. In terms of neurology, we're seeing people who are confused, who have poor concentration skills, who can't seem to, when they go back to work, they're working at half capacity from where they previously were. So all of these features are highly concerning in terms of these long haulers. It's a work in progress. We still don't understand it fully. There's an awful lot of work being done on it. As I said, we started up a clinic where we're seeing these patients now at Rocky View. There's one up in Edmonton, and there's clinics globally at this stage. So what's the mortality of COVID compared to other diseases? So we estimate the mortality of COVID now. So again, you have to take these figures with a slight pinch of salt, because there may be a considerable number of asymptomatic patients with COVID who aren't declaring themselves. Hence, this percentage of people who die from COVID might actually be falsely elevated. But from the data we have of individuals who've been diagnosed with COVID who pass away is 3.4% globally. Tuberculosis in Canada has a mortality of 0.33%, so a tenth of COVID. Seasonal influenza has a mortality of 0.1%. The Ebola virus obviously has a much higher mortality of between 40 and 62%. MERS, that's the Middle Eastern Respiratory Syndrome, caused by another coronavirus, has a lethal mortality of 37%. Now, sometimes a virus can be too lethal and it kills people too quickly before it gets a chance to spread. But this was a very concerning mortality rate. And this actually affected about half of these patients were hospital care workers caring for patients who had MERS. What about other diseases? So an acute myocardial infarction, the mortality rate is 7.7% at 30 days. What about a stroke? So an acute cerebrovascular attack at 30 days is a mortality of 28%. So that's just to try and put the mortality into perspective. So ladies and gentlemen, I really appreciate your time, and I'd love to take any questions or just talk in general about lung health, etc. It'd be my pleasure. And thank you again for listening.
It was absolutely amazing. Thank you very much, Dr. Mitchell. That historical data was absolutely fascinating and kind of puts our current situation in a little bit of perspective there, I think. But it's interesting to know how other generations have been affected by various pandemics. Excuse me. We have a couple of questions here coming up, and I would invite everyone at this point, if you have a question, by all means, there is a Q&A button at the bottom, and you're welcome to pop some questions in here for us. And and as you can see, I'm battling my own little bit here today, so bear with me.
I see there's a question here from Miss McLeod. Hi, it's a really interesting point that you make. So there is emerging evidence that people who have had a BCG vaccination are protected from COVID to a certain extent. The data is still emerging. And again, with all these, there's so many confounding points. So are people who have received, and it's not just BCG, people talk about the MMR vaccine or previous influenza vaccines. Is there a bit of a crossover there between COVID and an influenza vaccine because of viruses? And then the question becomes, well, do these people who have had a BCG or who've had MMRs, etc., come from societies or places where healthcare was taken more seriously, therefore are healthier by nature? So the analogy I always give is there is an absolute link between drownings and ice cream consumption. And that's because more people go swimming when the weather's hot and consume ice cream. So it doesn't mean just because you've had the vaccine that it's going to confer something, but it's still really interesting data to look at. And we do know that there can be cross-speciation in terms of vaccine protection. We know that the more regularly you have an influenza vaccine on a yearly basis, the less likely you are to get influenza in a current year compared to someone who just got an influenza vaccination that same year as well. So there is accumulating evidence to that. So you're correct, but we simply just don't know. So Dr. Mohammed, is if a second time infection, 4 cases is happening, what do you think about the success of vaccination? That raised an awful lot of hairs in terms of, how immunogenic is this? We know from another paper, in individuals who had mild infection, when we looked at their antibody titer, which is the antibody to the actual virus, it waned very quickly over a 4-month period. Now, if you had a severe infection, it didn't wane as quickly. So the more severe your infection, the longer your antibody levels lasted. But don't forget, we're not even 12 months into this pandemic, so we can't, it's such early days yet to say, but it's very concerning in terms of how long a vaccine can last. I mean, are we going to need a vaccine every year? Are we going to need a vaccine every 6 months? How contagious is COVID compared to seasonal influenza? We think it's about as contagious, so they seem to be similar. But obviously the mortality is significantly higher in COVID. So that's the concern. Do lungs have a different physiology on the front side of the body compared to the back side of the body? No, they have a slightly different physiology on the top compared to the bottom. So there's a reason when you get tuberculosis that predominantly TB affects the top of the lungs, is because the top of the lungs are more aerated. So more air gets to the top of the lungs, and TB loves air. So that's why it predominantly affects there. But otherwise, in terms of the actual, microscopic parenchyma per se, there's very little difference in the physiology on the front side compared with the back side. Doctor, do you believe this pandemic could repeat? What happened? Viral mutation is actually a concern on a yearly basis. So we get our blueprint from Australia when we do our seasonal influenza vaccine program. So this year there were 4 different types: H1N1, and H3, H4, H7, 9, and 7. So we get these. So and viruses do mutate. The big problem with influenza vaccination in the northern hemisphere is sometimes by the time the virus migrates up here, it's mutated, which means that the vaccine loses its efficacy. So could it mutate? Unfortunately, yes, it could. In many Asian countries and Australia, doxycycline and drugs. So again, I can't answer that with any sense of. The only thing I would mention, actually, Dr. Mohammed, is about 20% of people who are hospitalized with COVID develop a secondary bacterial infection. So whether the doxycycline as an antimicrobial or an antibacterial agent, as an antibiotic, is actually leading to a false signal of efficacy in terms of COVID, I don't know. But I don't know about ivermectin. I don't think so, but I don't know. Who should avoid getting vaccinations? No one. In mildly infected people, can sustained. Oh, sorry, Suzanne, I'm unsure what you mean there by glass capacity. Can you comment on vitamin D and COVID? Look, we know the bottom line. I mean, there are no studies that have really emerged to say vitamin D is a panacea or of any benefit in A, preventing COVID, and B, treating COVID. But we do know higher vitamin D levels. And vitamin D, it's not a vitamin, by the way, it's actually a hormone. And it's a calcium modulator. But higher vitamin D levels are actually excellent for everybody. So yes. There's evidence that vitamin D may actually have a beneficial effect in individuals with chronic asthma, for example. Is it easier to breathe when you're on your stomach? It's actually easier to breathe when you use gravity. Okay, so a lot of tests that we do to attest, so to see if the diaphragm is working, that's the bell-shaped muscle, up, down. That we do is to see if we get people to sit up, and we get them to breathe in and out and look at the strengths there, and we get them to lie flat because we've taken gravity out of the equation, and we see if the diaphragm is working as well. And if it's less than 20%, we know that they've got diaphragm problems. So on your stomach is something which we call a prone position, and that's come up in terms of COVID infection, whether people should lie on their stomach when they're in the hospital for periods of 4 hours, because there can be some better aeration in that region by doing that. However, asking someone who's very sick in hospital, who's out of breath, to lie on their stomach for 4 hours is very difficult. Is there any evidence radiation for cancer treatment weakens the lungs and therefore can be prone? So there's evidence that radiation treatment can weaken the lungs. About 5% of people who receive radiation treatment for breast cancer or lymphoma or lung cancer to the chest region will develop a chronic scarring disease called radiation pneumonitis and radiation fibrotic lung. So they are more susceptible to developing a more serious infection if they develop COVID. Yes, it's a simple answer to that. Anonymous attendee, vitamin D inhibit infection? I don't know. Probably not. In people with small bowel level of infestation, with a small level of, how damaging are the lung? Okay, so good question. We really don't have the data with that. We do know that the more severe your disease usually correlates with the higher volume of infection. So when they do the PCR, you have a much higher level of the actual COVID virus in your system. And that usually correlates with people who are more of those people fall into the long hauler category. So people with mild disease tend to do fine, people with more significant disease tend to do worse. Was this program? I think it was recorded.
Yes, we will be sending out a link once the recording is edited and ready to publish on our YouTube channel. So I'll be in contact with all the registrants to give them that information. We'll follow up to make sure that they do have your presentation after the fact as well.
Okay, lovely. Any suggestion of favipiravir? No, none. That's usually for influenza. Hopefully it comes out there, but nothing at all. It hasn't, I don't even, maybe it's been looked at. One good trial site that if you want to look that up, actually, Dr. Mohammed, is clinicaltrials.gov. And you just put in favipiravir and it'll let you know if there's a clinical trial going on with that. For asymptomatic signs. So, hi, San Diego. No offense, that's an oxymoron. So if you're asymptomatic, you've no signs. If you've signs, you're not asymptomatic. If that makes sense. So what are the things we need to monitor besides cough and shortness? So, well, actually, what's interesting is, I mean, I don't know if you noticed, I've got 3 young kids, so 6, 4, and 2, all in daycare. They all sniffled. They're like walking Petri dishes. And Dina Henschel finally has dropped sore throat and a sniffly nose from the list of exclusions from daycare. So I think a big one actually, San Diego, which I would say is a loss of taste or smell. Has there been any coronavirus pandemics? Yes. Well, no, not pandemics. Well, I suppose SARS was a pandemic. So back in 2003, it was a coronavirus. It actually, so in Toronto, I was actually at a meeting there, gosh, when we could fly. So it seems like a different lifetime in Toronto. And they were talking about the SARS pandemic, which originated in China in 2003. And about 20% of the respiratory department were taken out by it and 10% of them died. So yes, there was a pandemic due to COVID back in 2003. Oh, any suggestions about the type of material used for? There's so much, go through legitimate sources there, Dr. Mohammed, because there's so much crap out there of what people are talking. You don't need the N95s. But good surgical masks, good authenticated masks should be very good. No, we're not running short of respirators for ICU beds yet. And I hate saying that yet. I hope it doesn't become that case. We're starting to get a bit worried, especially going, the big concern. So it was actually, she's a professor of archaeology at UCD, architecture. She wrote a very informative piece in the Irish Times, which is an Irish newspaper, and she's had a peer-reviewed publication on this, talking about as the winter months approach and the fact that we shut our windows and don't let a peep of cold air in. So there's very little. That's actually a worry, for example, for radon in the Calgary region, because there is pockets of radon here. So if you think about it, if you've got air sweeping through when you're walking down a street, you're safer than you are if you're in an enclosed space where there's a lack of ventilation. So that's going to be a problem. My daughter's prone to asthma attacks. She's not more prone to getting COVID. She's more prone to having a serious outcome from getting COVID. So she's not more likely, but she's more likely to do worse than somebody who doesn't have asthma. My advice to her is that she religiously takes her inhalers. She's an asthma action plan. She liaises with her GP, or if she's an asthma specialist or respiratory specialist.
Would that advice be similar for people who have COPD, older adults particularly?
100%. Now, the one big thing actually that's come through from COVID, which has been very interesting, two things I'll mention actually, if I may. The first is the incidence of exacerbations from asthma and COPD have plummeted over the last 9 months, because these individuals are cocooning themselves that would make a Skellig-Michael monk embarrassed. So they're not going outside, they're really taking good precautions. So they're not exposing themselves to the usual pathogens that are just surrounding us all the time. They're not having grandchildren coming in from daycare with snotty noses saying, come on, grandma, give me a kiss. It's not happening like that. The second thing is influenza rates, and I said there in the southern hemisphere, that's where influenza kind of migrates to the northern hemisphere. Influenza rates in Australia are 1/10 of what they were on traditional seasonal influenza. That's very interesting. So open wounds, no, not to our knowledge. Okay, so we only know it's mucous membrane. So there's a particular reason for that in terms of what cell are actually on the mucous membranes compared to skin and open wounds that the virus can actually bind to and get in. Do you think this has changed lifestyle? Yes. I think in terms of, yeah, full stop. I think it's pressed the accelerator where we were all going to be in terms of remote technology in 10 or 15 years or 20 years. Absolutely. It's good. It's absolutely changed. So I do my clinic. I used to see everyone in person. Now I see 80%, 90% on the phone or virtually. And the feedback I'm getting is, so long as I can get my tests, my echo, my PFTs, my imaging, my bloods, my whatever, and you see me and you've got all the equipment and you can get on to the pharmacy, I'd much rather do it virtually. And it's not, and people aren't saying it just from a COVID risk. They're saying it actually fits in with my lifestyle easier. Like, I don't have to take half a day off work to come in and see the doctor. I can just actually say to my boss, listen, I'll need 20 minutes on the side when the doctor phones to go through everything. So that's going to change in terms of businesses. It's going to, it's really, I mean, the likes of Steve Bezos and Amazon, I couldn't have wished for a better pandemic in terms of online shopping, etc. So it's going to kill retail, it's going to kill downtowns, and businesses aren't going to have a 5-day week. You're going to be doing 2 days at home. It's going to change everything. Yeah.
one of the previous presenters that we had this month coined a new phrase. She said rather than referring to new normal, she prefers to refer to it as the now normal.
Yeah, exactly. Can you reuse medical masks if they're clean, not soiled, and they're left for a week? Surface contamination. I mean, I suppose, Corinne, if you're forced to, and we've all done that, where you're running down the road to pick up milk for the kids late at night, and you say, "Oh, Jesus, I forgot my new mask," and there's an old one sitting there in the car, and I stick it on. So you're not really supposed to, but you can. And I know you're talking about the impact cost. Again, you're not really supposed, and you know yourself, if you've worn a surgical mask for 2 or 3 days, it starts getting a bit frayed, etc. So I don't think it's actually as effective. I've heard COVID affect cognitive function. So it's too early to say whether they can recover, and it genuinely is. But I mean, look, the issue is this: even patients who undergo coronary artery bypass graft, when they have their cognitive function done pre-operatively and post-operatively at 3 months, 6 months, 9 months, we do know that there is a decrease in their cognitive capacities. We obviously hope that these people recover, but we don't have enough data, and there's not enough longitudinal studies to really answer that, I'm afraid.
We've had several very positive thank yous for the great presentation. Our anonymous again has asked if a person who's been diagnosed with early signs of lung disease and they stop smoking, would that halt the progression?
Yes.
You sound very adamant. Stop smoking.
I mean, you know, it's funny. It's just if you brought cigarettes out today, I mean, there's no way they get through regulation. Think about it. I want to introduce a product where 1 in 2 of the users will die.
All my respect for this amazing session. So much information. Thank you so much. That's our Carmen from Ireland.
Okay. Hi, Carmen.
Thank you for joining us. If there's no further questions, then I think that we can call this a very well-informed wrap. I'm going to attempt to, lots of brilliant presentations, best I've ever heard. There was one question in chat. Oh, that was Carmen, about the long haulers, how affected the people who didn't have a high level. I think you've answered that question during chat. But lots of thank yous, lots of great presentations. We really appreciate your wonderful information for us today. And I'm going to attempt before I wrap up completely, to get into a presentation here as well. And just basically, thank you so much, Dr. Mitchell, for the fabulous information. And before we let everybody go, just wanted to have everybody up to speed as to what is happening at Kirby Centre. We are up and running. Of course, with this new restriction, we are being extremely cautious of the numbers. But we do hope that if you have any signs of distress or concerns, by all means, Kirby's there for you. Contact the distress line. We are a mask distribution center. So if you do need masks, we have free masks for seniors. Just call our office and we can arrange to deliver some for you if you can't pop down. And lots of other services there. If you need, just check out our kirbynews.ca or our Kirby website, kirbycentre.com. And in vein of our presentations, Kirby Centre is offering its second flu clinic on November 4th. So we hope that you will take this information that you've gotten today and this month in stride, and call the 403-705-3246 to book your appointment and get your flu shot. Most important at this point, to help to eliminate some of the stress on our healthcare system. And our next presentation, hopefully you will join us for on our financial presentation, Wills and Estate Planning with Jonathan Ing from Underwood Gilhome. And following that, we will be kicking off Remembrance Day week with a presentation by Valor Canada about the soldiers from Calgary who were in the fighting 10th. And I think you'll find that in history quite interesting. We had planned on having our Remembrance Day service very small and live streaming it. With the news this week, we've had to take that down even more so. We will be Zooming a service to some extent on that day, and you can register for that at Kirby Centre Remembrance Day Service.eventbrite.ca, and we'll keep you informed about how we're going to be showing that. But we want to honor our long-standing commitment to honoring the military and fallen heroes. And of course, our members' holiday luncheon that we had hoped to have on a smaller scale has now been put on hold. So stay tuned to see what we might be able to do there to virtually have some holiday fun for our members. And then December 10th, we will have something that I think might be of great interest to people, retirement in a volatile market. People are concerned about what is happening with their retirement investments. And again, thank you. I think we may have lost Dr. Mitchell, but again, thank you very much to Dr. Mitchell for this wonderful information, and to Sanofi Pasteur who has supported our month-long presentations with an educational grant. We're very much appreciate and happy to have worked with Sanofi Pasteur again this year. And again, thank you all very much for joining us, and I hope that you were able to get the information that you need in order to help to keep you healthy. And I think there's a couple more questions, so before I completely close out, it appears as though we've lost Dr. Mitchell, but mainly, again, they were accolades, and thank you for the information. Great to get proper information to move forward with facts rather than the misinformation from internet. And I think that has been a problem for all of us, is receiving such mixed information. So once again, thank you all very much for joining us. And again, we will be sending you out an email to let you know how you can access the video to revisit or to share it with someone that you think might be interested in the information that could not attend the presentation. And thank you very much again for your support, and we look forward to seeing you at the next presentation. Thank you, and have a great day and a happy Halloween.